The integumentary system subsection includes codes on skin and subcutaneous structures such as lesions, wound closures, skin grafting, burn treatment, incision and drainage, Mohs, cryosurgery, and debridement. Nails, including debridement, excision, and reconstruction of the nail bed, and breast, including needle incision and excisions, biopsies, and all types of mastectomies. Here is an illustration of the skin and its components. Note the layers of the skin: epidermis, dermis, and subcutaneous tissues. A similar illustration is located in the workbook and the CPT book in the beginning of the surgery section. Debridement coding is based on the deepest level and commented size of the wound area. Please review guidelines in your CPT book and examples in your workbook. When performing debridement on a single wound, report depth using the deepest level of tissue removed. In multiple wounds, sum the surface area of those wounds that are at the same depth, but do not combine sums from different depths. Lesions. There are various types included. Moles, cysts, warts, neoplasms, and condylomas are among those noted here. Surgical removal and excision are the most common treatment for most skin lesions. Warts are also removed or destroyed by the use of liquid gas to freeze them off. Most lesions are benign, but if there's a lesion that is suspicious of being malignant, a biopsy is taken and analyzed in a laboratory for cancerous cells. The physician may elect to remove a lesion by the following techniques: shaving, paring, excising, or with the use of a laser. The coder should read the documentation thoroughly to determine the method used. Depending on the method of removal and the CPT code description, other documentation is also necessary to choose a code. Excision of lesions. There are two separate code ranges that can be found in this subsection to describe the excised site for benign, 11400 through 11471, and malignant, 11600 through 11646. To accurately code excision of lesions, the coding professional must be able to answer certain questions. Is it malignant or benign? What site or body part is involved? How large is the excised area in centimeters, including margins if applicable? And what kind of wound closure was performed? With reference to the lesion, a coder must note the total size of the excised area. A physician may take some normal-looking skin around the growth involved. Removal of the normal-looking skin is known as taking margins. This is done to be sure that no cancer cells are left behind. The pathology report typically provides the specimen size rather than the lesion or excised size. This is because the specimen tends to shrink. But this is not an accurate measurement according to the intent of the code assignment. Inches should be converted to centimeters when necessary. The slide shows how to arrive at the total size of an excised area with margins. This 2 centimeter lesion with margin and adding the margin is determined by measuring the greatest clinical diameter of the apparent lesion plus the margin required to complete excision, and that is lesion diameter plus the most narrow margins required equals the excised diameter. Please refer to your CPT book for further instructions. During the procedure in the integumentary system, such as excision, destruction, shave, removals, or removed tissues, is often submitted for pathologic examination. The obtaining of tissue is a routine component of such a procedure and is not considered a separate biopsy procedure and is not separately reported. Of note, the use of the biopsy procedure code 11100 and 11101 indicates that the procedure to obtain tissue for pathologic examination was performed independently or was unrelated or distinct from the other procedures or services provided at the time. Such biopsies are not considered a component of other procedures when performed on different lesions or different sites on the same date and are to be reported separately. When coding an excisional biopsy, the coder must read the operative report. The coder must verify if the doctors excised the tumor and then coded as such in the physician's service. The pathologist performs biopsy of tissue to determine morphology, that is, whether or not it's benign or malignant. Here we have a slide that shows a removal with margins. Please refer to your CPT book for further examples and explanations of excisions. Destruction of a lesion by laser, chemical, cryosurgery, and electrosurgery are located in the 17000 series of codes. Wound repairs are categories that are noted as simple, intermediate, and complex. Simple repairs are the most common and are for superficial wounds. The definition of simple repairs in the CPT book are those involving primarily epidermis or dermis or subcutaneous tissues without significant involvement of deeper structures and require a simple one-layer closure. This includes local anesthesia and chemical or electrocortisation of wounds not closed. Please read op notes for use of staples, sutures, or adhesive. Wounds that are closed with steri-strips are not coded as wound repair. They are coded as part of an evaluation and management service. Intermediate repairs are deeper layer closures. Look for documentation that is similar to the deep subcutaneous, etc., was closed with, etc. and so on. The definition of intermediate repairs in the CPT book are those repairs included that in the repair of wounds that, in addition to the description of a simple repair, require layered closure of one or more of the deeper layers of subcutaneous tissue and superficial fascia, in addition to the skin, epidermal, and dermal closure. Also, a single layer closure of heavily contaminated wound that requires extensive cleaning or removal of particulate matter also constitutes as an intermediate repair. Complex repairs are the least common. Look for more involved procedures than the intermediate. Complex repairs include the repair of the wound requiring more than layered closure, as noted, but also extensive undermining stents or retention sutures. Documentation must support the choice of codes. Please review the extensive definitions and instructions for coding repairs listed in your CPT book. Coding wound repairs requires making sure that the repair is in the same classification. It be simple, intermediate, or complex. If the repair is the same in the same anatomic site and the same classification, then you will add the total lengths and code the size in centimeters. Important note: only add wound repairs if criteria are met. Never add lesions. Skin grafts. Adjacent tissue transfers are addressed when skin is stretched over a defect. Skin replacement surgery is when coding this procedure, you will note if it was accomplished with autograft or skin substitutes. You will identify the size, location of the defect, and type of graft. Please read the definitions and instructions for coding skin replacement surgeries. Flaps are attached in stages over a defect. A flap is attached to donor site during the process. Measuring skin grafts in square centimeters. How big is 25 square centimeters? As a visual aid, the dollar bill is here to assist you. The slide here shows that a dollar bill is 2.61 inches wide and 6.14 inches long, which is 16.025 square inches. This translates to 6.62 centimeters wide and 15.60 centimeters long, or 103.24 square centimeters. 1 inch equals 2.54 centimeters. 25 square centimeters equals 1/4 the size of a dollar bill. This slide shows the skin graft harvest. Healthy tissue is taken from the thigh, and you can see the need for the graft on the finger and then the successful condition of the wound after the graft. In this illustration, we can see the depth of split thickness and full thickness with regard to the grafts. Breast procedures. A coder must analyze the documentation to determine the extent of the procedure. We should look to see if a biopsy was performed and was it a mastectomy. This slide shows the needle biopsy, the incision site, and then the needle retrieving a tissue sample of the affected area.